All right, so in this video, we're going to go through the concept of what epidemiology is, what that means, okay, and the measures that we use to derive epidemiology and the data associated, particularly around Australians, okay? Now, I'm not going to go through any data specifically in this video. That is something that we're going to do as a class activity, or I might film it as a separate video after this one. Let's go. Okay, so in the title is the main focus of this video, this word epidemiology. Okay, you may have heard this before, you may not. It is very, very important as far as our HMS stuff is concerned. So epidemiology, or if you are an epidemiologist, it is you are tasked with studying the health and disease in populations or groups, okay, over time. So in the broader sense, we're looking at the health and disease data of Australians, but we can break that down into different population groups that live in Australians, such as First Nations people and non-Aboriginal and Torres Strait Islander peoples. We could look at people who live in Australia from non-English speaking backgrounds. We could look at people who have immigrated to Australia or refugees from other countries. We could look at people who live on the coast as opposed to people that live inland, okay? We could look at the people who live in different states, so compare the health of New South Wales compared to people that live in Western Australia, for example, okay? You get the point, all right? It is you pick a certain group or a population of people, and then you can monitor health, and so levels of health, so good health and bad health over time. So we use this data to do a variety of things. There are more reasons than this, but these are probably the most important reasons. So our first one, we've got identifying health issues in certain groups and regions, okay? So for example, the big one, which I always go back to because it's all very fresh in everyone's mind, is COVID-19, all right? Wasn't on the map at all. All of a sudden, many people are popping up testing positive to COVID-19, and all of a sudden people are getting very sick and hospitalized from COVID-19, and then unfortunately some people died from COVID-19, all right? So epidemiology data was used to detect that and track that, and then could see it rising, and because of its rising, it was able to then, the third point here, allocating resources to disease and illnesses with high levels of prevalence, okay? Or high potential for prevention, which COVID-19 was completely preventable. So we can also use epidemiology data to identify health inequities between groups and regions. So if you look at something like cardiovascular disease, and you look at people who live on the coastline of Australia as opposed to people that live inland in Australia, you will find that there is a slight inequity there as to the mortality rates of cardiovascular disease being higher for people that live in rural and remote areas. That doesn't necessarily mean, and so then part of epidemiology, I should expand on that a bit more, doesn't necessarily mean that people just by living in the, towards the centre of Australia doesn't naturally make you more unhealthy. What it could identify though, is that if 100 people on the coastline went into cardiac arrest and 100 people inland went into cardiac arrest, out of those 100 people in both population areas, who's going to get treatment sooner? Well, it's probably going to be the people on the coast because they live closer to more hospitals, all right? And that could be the difference between life and death sometimes. So therefore, epidemiologists use that data and they're like, well, we might need to look at putting in another hospital inland New South Wales, or we need to probably mobilise some more air units to be able to get people who have these issues inland New South Wales out to hospitals quicker. We can also use epidemiology data to evaluate the effectiveness of current health promotion campaigns and strategies, So for example, if we're running a, tobacco strategy or a vaping strategy, okay? So obviously data isn't going to show up immediately from that strategy. So let's say you started a anti-vaping campaign on the 1st of January this year. You're not really going to see a reduction in respiratory illnesses caused from vaping like in February, but maybe by halfway through the year, you might start to see a slight reduction. And then certainly 12 months, 18 months, 24 months later, hopefully there is a trend downwards. So when we do talk about the data like I said, in a separate video or just in class. It's really great if you can remember numbers, but probably more importantly is how that data is trending. Are things going up? Are things going down? Are they getting worse or better? All right. And all of that stuff is identified through epidemiology. All right. So if data is really, really important, what doesn't the data tell us? Okay. Remember, data is just numbers, statistics. Okay. The data doesn't explain why these things are happening, okay? Why are things going up and down? Why are people getting sick? Why are people healthy? We don't know, okay? It's just a number. Why are certain groups more ill than others, okay? Why are rates of illnesses rising or falling? Why are people dying from something that shouldn't kill them? Why did 4 people in a family of 5 get sick, but the 5th didn't? Data doesn't tell us that stuff, okay? So the Australian Bureau of Statistics, the ABS, all right, in conjunction with the Australian Institute of Health and Welfare, the AIHW, forever known as ABS and AIHW, I'm not writing that out again, they collect the data. They take the data, they produce reports, okay? Now the AIHW then has epidemiologists as part of their team. So then the epidemiologists take the data and they try and work out the whys, okay? They look at the data, they look at the trends, they look at population groups, okay? They speak to doctors and nurses and people who work in certain regions of Australia. And they're like, well, you know, what do you notice? And then they compile a report and try and explain the whys, okay? So this is all like a very neat little system that operates together, okay? There are some issues though with data collection, and I'll just quickly put them up too. So there are some issues with data collection, okay? And this is also why epidemiologists have a job. They need to sort through these things to try and work out what's actually real or significant and what is not. So for example, self-reporting, so through the ABS, can be inaccurate, all right? So there is a census that happens, and largely, I think, is it every 6 years in Australia? I probably should have looked that up. I'll let you know. And that you got to fill it out yourself, okay? So the last time we did it, it was digital, which was great, but it used to be on, you know, pen and paper, and you have to like self-report, et cetera, et cetera. You can just make that up, all right? You don't have to answer that accurately, okay? The ABS is obviously relying on you to answer that accurately because then it helps guide programs and systems and strategies, et cetera. But it may not be accurate, okay? Now, especially, I should probably add here, with the since COVID, the invention of telehealth systems has added to this self-reporting data, which could be inaccurate. So for example, you can go onto like an eScript service, okay? So eScript, right? Let's say you want a script for antibiotics, but you don't want to go to a doctor. Who has time for that? You go online and you're like, hey, need some antibiotics, whatever. And then someone on the phone, not video call, they just call you on the phone and they say, hey, can you describe the symptoms you're having? And then you just Google symptoms antibiotics required for. Oh, I've got like a deep, heavy cough. It hurts when I breathe in. I bring up phlegm from my lungs regularly and it's brown. And they're like, okay, yep, sounds like you do need antibiotics. And they write you a script, send it off, okay? You may not be sick at all. I don't know why you would want antibiotics if you're not sick. But the point remains that then goes to medical data statistics to guide it, because if all of a sudden everyone's ringing up for antibiotics, then there must be some terrible, terrible thing happening in Newcastle. But it turns out everyone was just faking the system. So self-reporting can be inaccurate and therefore it can lead into inaccurate data. The second point, not all sick people actually get help. Okay, especially people from like low SES backgrounds, okay? So if you don't have much money, and I can tell you now, as a parent of 2 children, who I love very dearly, the thought of having 85 spare dollars to go to a doctor is a little bit daunting. So we actively try and do things to make sure we don't have to go to the doctor, okay? Obviously, if my kids are really sick and I'm really sick or my wife's really sick, we will go to the doctor, okay? But we do so many things before we get to that point, all right? Like I know, for example, when my girls were little, like really little, we had like friends in like parents groups and whatever, and they were like up at the hospital all the time. Oh, we went to the hospital last night, they had a bad cough. Oh, went to the hospital, they had a temperature. Oh, went to the hospital because they haven't been to the toilet in 3 days. And like, we never did that, all right? We didn't have money for that. But people are like, $500, $500, $500 for the hospital. We just don't do that. Because, you know, I'm not saying I'm low SES either, okay? I'm very not. But what I'm saying is there are lots of people in a much worse financial situation than myself. And if I'm questioning going to a GP and the hospital because of cost-wise, then lots of other people are like, it ain't happening at all. So you could have a whole group of people who, you know, live in like some random town, okay? And they're all suffering from some really, really awful condition. And no one goes and gets help for it, because no one can afford it, because they live in a low SES area. And because no one gets help, it doesn't get recorded in the data. And because it doesn't get recorded in the data, we don't actually do anything. We don't implement any programs or strategies to help those people in the future to not get X, Y, Z disease, all right? Hopefully you can see the kick-on effect here. Third one, not all underlying conditions are diagnosed. So, you know, someone might go and they might to the GP and they might say, hey, I've, you know, got these symptoms, blah, 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 and the GP might diagnose them with X condition, okay? You have pretty sure you have this thing, take this medication, and hopefully you'll be right. And then it turns out like they had something completely different and they got really, really sick and went to the hospital. But when they get to the hospital on their admission chart, it will say that they had the condition that their GP diagnosed them for. So they treat them for that condition, but all along it was this other thing, okay? So like I know, for example, there are people that have had like they've been overseas, they've come back and they've had like parasites, all right? Like wormy type things in their body. It's just been messing them up. But like the GPs and the hospitals have diagnosed them with things like Crohn's and celiac and things like that, but it's been something completely different and they've just missed it, all right? So all of a sudden the data goes, well, these people, we've got an increase at the moment in celiac disease. Maybe there's something going wrong with the wheat industry or something like that. Whereas it turns out there's actually like a parasite epidemic and we need to kill them with fire or whatever you kill parasites with. I know you don't kill them with fire. It was just a joke. Fourth one, small sample size produces inaccuracies in data, okay? So we could say like, let's say in Newcastle, there was 57 people yesterday who got the flu, and they all went to the GP and they were all diagnosed with influenza type A, all right? The ABS might be flagged by 57 people, and then someone might say, well, actually there must be an influenza A outbreak in Newcastle. Let's like go and smash that with a whole bunch of resources and strategies and stuff. But it turns out those 57 people were just unlucky, and they're the only 57 people in Newcastle that have influenza A, and there's like 1 million people that live here. That's an insignificant amount, all right? But it just so happened that on one day, all those people went, you know, you can see how like a small sample size can put red flags in the system, but it's not actually an issue. So these are our issues with data collection. Right, so when we go through our statistics in class or in a separate video, I probably will do a video, just why not? Why not? I love spending my free time standing in front of a camera. These are the main statistics that you guys will need to get familiar with, okay? And in most cases, it'll be like a top 5 that you need to remember, and you should write about them in your answers, okay? So our main ones, we've got mortality, morbidity, infant mortality, and life expectancy. Mortality. Mortality is very simple. The rates of death from certain causes, in given populations, okay? When we talk about statistics here in Australia, we have mortality rates for all Australians. We have mortality rates for First Nations people, which are different. We have mortality rates for males, and we have mortality rates for females, okay? And you will probably need to know all 4 of those in like a top 5. We also have morbidity rates, okay, broken up into the same degrees, but also with morbidity and mortality, we can also break it down into age categories, which we'll also talk about in that statistics video. But morbidity is the rate of illness or disease or injury from certain causes. So basically things that you go to the GP for or hospitalizations which don't result in death, okay? That counts towards a morbidity statistic, all right? And you can think that a lot of the morbidity top 5 might actually be different to mortality top 5 because things that you may go to the hospital regularly for aren't necessarily things that are going to kill you. Now, infant mortality is an interesting one. It is the rate of death from certain causes per 1,000 live births, and the death has to occur in the first 12 months, so under the age of 1. All right? So we're talking about newborn babies who are live birth, and then in the first 12 months, unfortunately, something horribly wrong has happened. We can use those statistics to, which are separate from our mortality statistics. And our last one is life expectancy. Life expectancy is the calculated age you should live to on average from your birth. So, for example, like my life expectancy as someone who was born in 1984 is significantly less than your life expectancy. And I'm assuming born around 2008, 2009-ish, okay? But you get the point, all right? And my daughter's life expectancy, 2016, 2019, is more than your life expectancy because it is one of the things that is constantly trending upwards. But like I said, we'll talk about that in a separate video. Okay, so the last thing I want to cover in this video are our measures of epidemiology, okay? So we've talked about the main statistics that we're going to go through, and then you need to look at these things. So these are the things that actually measure the data, all right? Incidence rates and prevalence rates. With this data, epidemiologists use this data to do the things that we spoke about at the very, very start of the video, okay? Showing increasing rates of disease or illness or causes of death, and then from that can start to implement protective measures, can implement strategies and campaigns to hopefully bring the data down, or you could allocate funding and resources. So these are the measures that we're looking at, all right? They're very, very similar, but hopefully I've given clear examples here to separate them in your minds so you don't get confused. So incidence, first of all. Incidence is the number of new cases of illness or disease in a specified period. For example, this week, from the 8th of June to the 14th of June, there was a 17.8% increase in influenza A cases in New South Wales. I've just made this statistic up for the record. This is not accurate data, but I'm saying in a 1 week period, the data could show that there was a 17.8% increase in influenza A, all right? That seems pretty significant. So influenza A is picking up. Sounds bad, right? Because we're getting into winter, more people are getting influenza A. Maybe we've got an influenza A epidemic about to hit, right? However, hold that thought, all right? This is why people get paid money to analyze this data. Isn't it exciting? I love this stuff. Anyway, it's not me. Prevalence rates is the other thing we need to look at. Prevalence rates are the number of cases of illness and disease at a specified time. So for example, on the 14th of June, which is in this range here, there are 14,736 people in New South Wales with influenza A. So this one's showing that there's almost been an 18% increase over in a week's time. This one's showing that there's 14,736 people with influenza A on a specified date. But we use this data to track our trends. So this seems bad and this seems bad, but this number could actually be a 24% reduction in cases from the 14th of June last year. So even though it might be increasing at the moment, okay, what epidemiologists will do is they'll look back through the data and they'll go, okay, well, at this same time last year, there was also influenza A cases increasing because it's getting into winter, people get sick, etc. However, this number is significantly lower than what it was last year, so we probably don't need to implement any drastic measures for influenza A at the moment because the data seems to be trending as it usually does, or if anything, this is a reduction, so we're actually doing better than what we were this time last year. So you can see how like incidence and prevalence rates can identify issues. So this is like our first red flag to prevent measures, but then you need to also incorporate the prevalence data, looking at the trend over time to see whether it's actually really, really important or it's not as significant as it was. And that is going to end our video on the epidemiology and the health of Australians. And I will do a follow-up on this with looking at our current statistics. Thanks.